But what nobody tells you is that one simple mistake at night could be making your Sjogren's symptoms dramatically worse. And most people over 60 do it every single night, without even realizing it. Not because they are careless. Because nobody told them. Not their GP. Not their rheumatologist. Nobody. And this one mistake could be the exact reason you wake up every morning feeling worse than when you went to bed. I'm going to show you 7 of these mistakes today. Each one with the science, the physiology, the why, and exactly what to say to your doctor about it. Before we go any further, I need to tell you about something. Because this video is going to give you a lot of information. And I know that when there's a lot of information, it can be hard to know where to start with your own symptoms. And if you want my downloadable symptom map, just type symptom map in the comments. I'll heart your comment and drop the link. Let's get into it. 7 nighttime mistakes. One by one. And you tell me how many you recognize. Before we go through the mistakes, I need to give you the foundation. Because most people with Sjogren's were told they have dry eyes and dry mouth. That's technically true. But that description misses almost everything. Sjogren's is a systemic autoimmune disease. Systemic means it doesn't just affect your eyes and mouth. It affects your entire body, your nervous system, joints, kidneys, lungs, brain, skin, blood vessels. Your immune system produces antibodies that attack your own moisture-producing glands. These are the glands responsible for producing tears, saliva, mucus, and protective secretions throughout your entire body. Immune cells called lymphocytes infiltrate these glands, causing destruction and permanent scarring. The damage is often irreversible, which is why protecting what function remains is critical. Over 4 million Americans are estimated to have Sjogren's, and up to 50% remain undiagnosed. The average time from first symptoms to diagnosis is 9 years. 9 years of not knowing. 90% of Sjogren's patients are women. Most are diagnosed in their 40s and 60s. And 50% of patients have systemic involvement beyond dryness, nerve pain, joint disease, fatigue, cognitive issues. And nighttime, those 7 to 9 hours when you think you're resting, is when the body runs its most important biological processes. Immune surveillance, cell repair, inflammatory regulation, hormone cycling, gland recovery. If what you do before and during sleep disrupts those processes, your symptoms don't recover overnight. They accumulate. Night by night. Week by week. That is what we are correcting today. Let me describe your morning to you. You open your eyes and they feel like sandpaper dragging across glass. Your mouth is so dry your tongue is stuck to the roof of it. Your joints ache before you've moved. Your head feels heavy, foggy, disconnected. And your body feels like it did not rest even though you slept for 7 hours. And you don't know why. You've tried going to bed earlier, later. Different pillows. Different positions. Some mornings are better. Some are worse. It feels completely random. But here is what I need you to hear. It is not random. There is a biological pattern happening every night inside your body. A pattern that connects directly to everything you feel when you wake up. And once I show you this pattern, once you see it clearly, you will never look at your morning symptoms the same way again. And if you want to track your own pattern as we go through this, that is exactly what the symptom map in the description is built for. Page by page. Symptom by symptom. Map to your own body. Before we go through each mistake, I want to give you something most doctors don't give you. The context. Because once you understand what is supposed to happen during sleep in a healthy body, you'll immediately understand how Sjogren's disrupts it. Between 10 at night and 2 in the morning, growth hormone surges, driving tissue repair. The liver clears inflammatory metabolites. Cortisol, your anti-inflammatory stress hormone, drops to its lowest level. Between 2 and 6 in the morning, cortisol begins rising again. Immune surveillance becomes highly active. Pro-inflammatory cytokines including Illinois 6, TNF-alpha, and Illinois 1-beta follow a circadian rhythm, often peaking between 3 and 7 in the morning. In Sjogren's, these cytokines are chronically elevated, which means your inflammatory window, the most biologically active immune period of the night, overlaps almost perfectly with the final hours of your sleep. Let that land for a moment. Your most inflammatory immune hours happen while you are asleep. This is why Sjogren's patients so often describe their worst symptoms in the morning. It isn't coincidence. It's circadian biology meeting autoimmune inflammation. And there's something else most people are never told. Sjogren's is one of the few autoimmune diseases with significant autonomic nervous system involvement. The autonomic nervous system controls glandular secretion through parasympathetic nerve signals. Research has shown that Sjogren's patients frequently have reduced parasympathetic tone and elevated fight-or-flight activity. At night, healthy bodies shift decisively toward rest and recovery. In Sjogren's, this shift is impaired, meaning your glands receive fewer signals to lubricate. Your body remains in a low-grade stress state, and inflammatory activity stays elevated even during sleep. This is the foundation. Now let's build on it. Here are the 7 nighttime mistakes. Exactly what each one is doing to your biology. Mistake number 1. Sleeping with your mouth open. You fall asleep. Your body fully relaxes. Your jaw loosens. Your tongue drops back slightly. And for the next 7 or 8 hours you breathe through your mouth. You don't know you're doing it. Nobody does. But your body knows. By 3 in the morning your mouth is completely desiccated. The protective saliva coating your teeth and gums is gone. Your throat is parched and irritated. Every single breath pulling more dry air across tissue that has nothing left to give. Here is what most people don't understand about saliva. Healthy adults produce between half a liter and 1.5 liters of saliva per day. Sjogren's patients often produce a fraction of this. And saliva isn't just moisture. It contains frontline immune antibodies, antimicrobial proteins called lactoferrin and lysozyme, protective coating proteins called mucins, a pH buffer to prevent acid damage, and a tissue repair signal called epidermal growth factor. When mouth breathing strips away what little saliva remains, it removes all of these protective mechanisms simultaneously. The result is dramatically elevated risk of dental decay, oral infections, mucosal ulcerations, and chronic oral inflammation, which feeds back directly into the systemic inflammatory load. And there's another layer to this. Your nasal passages do something critical. They warm, humidify, and filter incoming air before it reaches your airways. When you breathe through your nose, air arrives at your airways at nearly 100% relative humidity. When you breathe through your mouth, air arrives at 50 to 70% even in a normal room. In someone with Sjogren's, where airway mucous membranes are already compromised, this unhumidified air creates microtrauma across the lining of the throat and airways. Over hours this triggers local inflammation, adding to the systemic inflammatory cascade. You think this is just dry mouth. Part of the condition. Most people accept it without question. But acceptance without understanding is the problem. This is why your mouth feels like a desert at 6 in the morning. This is why your first words of the day come out cracked and painful. 8 hours of unprotected airflow across already vulnerable tissue. Every night. Compounding. This is not your fault. This is physiology. And now that you know what it is, you can do something about it. Ask your doctor about mouth taping with medical-grade tape if you have no nasal obstruction. Studies show this improves sleep quality and reduces oral dryness. Ask about a bedside coolmist ultrasonic humidifier set to 50 to 60% relative humidity. Ask about biotin oral balance gel applied to the inside of the cheeks before sleep. It contains the same enzyme system found in saliva, and it lasts several hours. And at your next appointment, try saying this. I'm noticing my mouth is completely dry every morning and I'm waking with throat irritation. I'd like to discuss whether nocturnal mouth breathing is contributing to my Sjogren's symptom load, and whether a sleep study or airway assessment would be appropriate. But it doesn't stop there. Because the environment you sleep in is making this worse. Mistake number 2. Sleeping in low humidity heated air. You set the thermostat. Pull the blankets up. The room is warm. Comfortable. You drift off. What you don't see is what that heated air is doing while you sleep. The World Health Organization recommends indoor humidity between 40 and 60%. When you run central heating, indoor humidity routinely drops to 15 to 25%. Drier than most deserts. The Sahara Desert averages approximately 25% relative humidity. At 20% indoor humidity, tear evaporation from the ocular surface increases by 40 to 60% compared to a properly humidified room. Nasal mucous membranes dry out and crack. Skin barrier function deteriorates. And for someone with Sjogren's whose moisture production is already severely compromised, sleeping in dry air is the biological equivalent of running a machine that is already low on oil at full speed for 8 hours straight. And here is what this does to your eyes overnight. The tear film has 3 layers. The outer lipid layer produced by the meibomian glands in your eyelids. The aqueous layer produced by the lacrimal glands which are compromised in Sjogren's. And the inner mucin layer produced by goblet cells in the conjunctiva which is also affected. In dry air the lipid layer destabilizes and the tear film breaks up faster. In healthy eyes the tear film lasts over 10 seconds before breaking. In Sjogren's patients it is often under 5 seconds. Sometimes under 2. In low humidity this drops even further. When the tear film breaks the corneal surface is exposed to air. Repeated exposure causes microdamage across the cornea. Overnight without blinking to redistribute tears this damage accumulates silently for hours. This is why your eyes feel like they've been rubbed with sandpaper the moment you open them. This is why your sinuses feel congested even when you're not sick. This is where chronic ocular surface damage begins silently over years. Target your bedroom humidity at 45 to 55% using a Coolmist ultrasonic humidifier. Check it with an inexpensive hygrometer. And if your eye symptoms are severe, ask your ophthalmologist about moisture chamber goggles, silicone-edged eye cups that create a humid microenvironment around each eye while you sleep. At your next appointment try saying this. My eye symptoms are consistently worse in the morning. I'm wondering whether low bedroom humidity is contributing to corneal surface damage overnight. Can we discuss tear film breakup time testing and whether moisture chamber goggles would be appropriate for me? And this is where it gets worse. Because what you take before bed may be silently working against you. Mistake number 3. Taking anticholinergic medications at night without knowing their effect. Before bed you take your medications. Faithfully. Blood pressure. Cholesterol. A sleep aid. An antihistamine. An antidepressant. Doctor prescribed. Treating your other conditions. But some of them have a side effect nobody told you about. The parasympathetic nervous system controls your moisture-producing glands through a chemical messenger called acetylcholine. When acetylcholine binds to receptors on your salivary and lacrimal glands, they produce moisture. Medications with anticholinergic effects block these receptors. The result is reduced glandular secretion across the entire body. In someone without Sjogren's this is a manageable inconvenience, mild dry mouth, maybe some blurred vision. In someone with Sjogren's whose glands already produce a fraction of normal output, anticholinergic medications can reduce what little remains to almost nothing. The body has no reserve to compensate. Antihistamines like diphenhydramine found in Benadryl, ZZZquil, and Unisum are among the most anticholinergic substances available without a prescription. Antidepressants including amitriptyline, nortriptyline, doxepin, and paroxetine, frequently prescribed for Sjogren's-related pain and sleep, are also strongly anticholinergic. Bladder medications like oxybutynin, tolterodine, and sulfenacin prescribed for overactive bladder, which is common in older women, are extremely anticholinergic. Muscle relaxants like cyclobenzaprine carry significant anticholinergic load. And quetiapine, often used off-label for sleep, has moderate to high anticholinergic effect. Researchers use something called the anticholinergic cognitive burden scale to measure the cumulative load of anticholinergic medications. Studies published in JAMA Internal Medicine show that high cumulative anticholinergic burden is associated with significantly elevated risk of cognitive decline and neurological impairment, particularly in adults over 60. For Sjogren's patients who already face risk of cognitive involvement, this cumulative burden is especially critical. Your total anticholinergic load across all medications may be far higher than any individual prescription suggests. This is why some mornings are dramatically worse than others without explanation. The nights you took the extra sleep aid. The nights you took the antihistamine. Those are often your worst mornings. The pattern was real. You just didn't have the key to read it. Ask your pharmacist to calculate your anticholinergic burden score across all current medications. This is a free service at most pharmacies and takes under 5 minutes. If your score is high, ask about alternatives. Oxybutynin for bladder issues can often be replaced with mirabegron, which has zero anticholinergic activity. Amitriptyline can sometimes be replaced with options that carry far lower anticholinergic profiles. At your next appointment, try saying this. I'd like to review my complete medication list specifically for anticholinergic activity. I have Sjogren's and I want to understand whether any of my medications are amplifying my dryness symptoms overnight. Can we calculate my anticholinergic burden score together? That's not the real problem. The next mistake involves your anatomy and gravity. Mistake number 4. Sleeping completely flat. You get into bed. Lie flat. Pull the covers up. Standard. Normal. The way you've always slept. Nothing unusual about it. But here is what's happening inside your body while you sleep. The paranasal sinuses drain by gravity when you're upright. Lying flat, drainage slows and mucus pools in the sinus cavities. In Sjogren's, sinus mucosa is already chronically dry and inflamed. Pooled thickened mucus further occludes the sinuses, creating an environment for low-grade infection and chronic inflammation. Even without classic heartburn symptoms, many adults experience nighttime acid microreflux when lying flat. Stomach acid reaches the throat and larynx, causing inflammation, dryness, and mucous membrane irritation. In Sjogren's, where the esophageal mucosa is already compromised, this is significantly more damaging. And lying flat impairs eustachian tube drainage from the middle ear. Sjogren's patients have elevated rates of middle ear involvement, and chronic fluid accumulation can worsen tinnitus and hearing changes. You wake up and your sinuses feel blocked, not infected, just thick. Your voice is hoarse before you've said a word. There's a rawness in the back of your throat that takes an hour to clear. None of this seems connected to how you slept. But it is. Studies consistently show that 30 to 45 degree head elevation reduces nighttime reflux episodes by 60 to 70% and improves sinus drainage significantly. For Sjogren's patients, reducing throat and sinus irritation at night means reducing one additional inflammatory trigger with every sleep cycle. Elevate the head of your bed 4 to 6 inches using bed risers under the bed frame legs. This is more effective than stacking pillows, which can cause neck strain. A 30-degree wedge pillow is an excellent alternative and costs between $30 and $60. Also, avoid eating within 3 hours of bedtime to minimize reflux risk. At your next appointment, try saying this. I consistently wake with sinus congestion, morning hoarseness, and throat dryness beyond my Sjogren's baseline. Could laryngopharyngeal reflux or nocturnal sinus drainage issues be contributing? Is a 24-hour pH impedance study or sinus imaging appropriate? But it doesn't stop there. Because what you do in the hour before bed affects your immune system all night. Mistake number 5. Screen use in the hour before bed. Before bed you reach for your phone. Or the tablet. Or the TV is still on. Winding down. Just scrolling. Just watching something light. It feels like relaxation. It feels harmless. But here is what screens are doing inside your body. Melatonin is produced by the pineal gland in response to darkness, beginning around 9 to 10 at night and peaking between 2 and 4 in the morning. Blue wavelength light emitted strongly by phones, tablets, and LED screens suppresses melatonin production even at low intensities. But here is what most people do not know. Melatonin is not just a sleep hormone. It is an immune regulator. Research shows that melatonin inhibits pro-inflammatory cytokine production, including the same Illinois 6 and TNF-alpha cytokines that are chronically elevated in Sjogren's. It reduces activation of the master inflammatory pathway involved in Sjogren's pathology. It supports the regulatory immune cells that are supposed to prevent the immune system from attacking self-tissue, cells that are dysfunctional in autoimmunity. And it has direct protective effects on exocrine gland tissue. When you suppress melatonin with screen light, you remove its anti-inflammatory protection during the exact hours when your immune system is most active. A study published in Clinical and Experimental Rheumatology found that Sjogren's patients had significantly lower melatonin levels compared to healthy controls, and that lower melatonin correlated directly with higher inflammatory markers and worse fatigue scores. This is why your brain fog is heavier on the mornings after late-night scrolling. This is why your fatigue on those mornings feels deeper than usual. The inflammation had longer to build. And fewer things to slow it down. Implement a 60-minute screen curfew before your intended sleep time. If screen use is unavoidable, use blue light blocking glasses that filter 90% or more of blue light. Consider 0.5 to 1 mg of melatonin 30 minutes before bed. At this low dose, research suggests it acts as a circadian signal and the anti-inflammatory effects are maximized. Higher doses may actually disrupt immune regulation. Discuss this with your rheumatologist. At your next appointment, try saying this. I've read that melatonin has immunomodulatory effects relevant to Sjogren's. I'd like to discuss whether low-dose melatonin supplementation is appropriate for me, and whether there are any concerns about interactions with my current medications or disease activity. And this is where it gets worse. Because your eyes are suffering overnight in a way that accumulates silently. Mistake number 6. Not protecting your eyes overnight. You close your eyes and assume they're resting. They've been dry and irritated all day. Sleep will help. Not always. Not in Sjogren's. Nocturnal logophthalmos is incomplete eyelid closure during sleep. It affects up to 20% of the general population and is more common in older adults and in autoimmune disease. Most people are completely unaware they have it because it occurs during sleep. Even a 2 mm gap in eyelid closure exposes the cornea, the transparent front surface of the eye, to room air for hours. In someone with normal tear film this is manageable. In Sjogren's, where aqueous tear production is severely reduced, even a small gap can cause microdamage across the entire corneal surface. It can cause filaments of mucus and degenerated cells to adhere to the cornea, causing severe pain on waking. It can cause recurrent corneal erosion syndrome, and over time progressive corneal surface damage that can affect vision. The meibomian glands in your eyelids produce the lipid layer of the tear film, which prevents tear evaporation. Meibomian gland dysfunction affects 50 to 70% of Sjogren's patients. Without adequate lipid layer function, tears evaporate within seconds even when the watery component is being produced. At night, without blinking to replenish the tear film, evaporative dry eye devastates the corneal surface within just a few hours. This is where the most severe morning eye symptoms come from. Not just dryness, pain, light sensitivity, the feeling that something is in your eye, and over time progressive corneal surface damage that your ophthalmologist may not connect to nighttime exposure because nobody asked about your sleep environment. Speak to a dry eye ophthalmologist or corneal specialist about slit lamp examination with dye staining to assess corneal surface damage. Ask about meibomian gland imaging to assess gland dropout. Ask about moisture chamber goggles for sleep. Ask about high viscosity lubricating eye gel at bedtime. Regular drops evaporate within minutes, but gel formulations last 3 to 6 hours. At your next appointment, try saying this: my eye symptoms are consistently worst immediately on waking. I'd like to be tested for nocturnal logophthalmos and have corneal surface staining done to assess for overnight damage. Is moisture chamber goggle therapy appropriate for my level of disease? That's not the real problem yet. Because everything we've discussed compounds when the foundation is wrong. And the foundation is hydration. Mistake number 7. Going to bed in chronic low-grade dehydration. You had dinner. A glass of water or 2. You don't feel particularly thirsty. So you don't drink more. You go to bed. But your body's thirst signal is broken. And you may not know it. Research consistently demonstrates that thirst sensitivity declines significantly with age. By age 65, the sensors in the brain that detect rising blood concentration and trigger thirst become significantly less sensitive. Adults over 60 can be 1 to 2% dehydrated, clinically meaningful dehydration, without experiencing any thirst at all. And in Sjogren's patients, chronic oral dryness creates a masking effect. The sensation of constant dry mouth becomes background noise. And genuine thirst cannot be distinguished from the baseline dryness that is always present. 2 independent mechanisms simultaneously impairing the thirst signal. Research published in Frontiers in Immunology demonstrated that even mild dehydration, as little as 1 to 2% of body weight, significantly increases circulating Illinois 6, TNF-alpha, and Illinois 1 beta, the primary pro-inflammatory cytokines that are already elevated in Sjogren's. In Sjogren's, going to bed dehydrated means pressing the accelerator down on your inflammatory response for the entire night. And there is a kidney connection most patients are never told about. Approximately 5% of Sjogren's patients have overt kidney involvement. But subclinical kidney tubular dysfunction is estimated at 30 to 50% in some studies. The most common manifestation is distal renal tubular acidosis, where the kidneys fail to adequately concentrate urine. This means Sjogren's patients may lose more water in their urine than expected. Going to bed dehydrated when kidney water retention is also impaired is a compounded problem most patients are never informed of. This is where people unknowingly make it worse night after night for years. Every other mistake on this list is amplified by dehydration. Low humidity dries you out faster. Mouth breathing strips more. Medications reduce more. Dehydration is the multiplier underneath all of it. Calculate your personal daily fluid target. Body weight in kilograms multiplied by 35 milliliters gives your daily baseline. Drink 1 glass of room temperature water 30 minutes before bed. Track your first morning urine color, pale straw yellow means adequate hydration. Amber or darker means dehydration. And avoid alcohol within 3 hours of bed. It suppresses the hormone that tells your kidneys to retain water, causing significant overnight fluid loss. At your next appointment, try saying this. I'd like to be tested for renal tubular acidosis and subclinical kidney involvement related to my Sjogren's. Can we check urine pH, electrolytes, and creatinine and discuss whether a nephrology referral is warranted? Now I want you to see the full picture. Because none of these mistakes exists in isolation. They compound each other. Layer by layer. Hour by hour. Night by night. Here is what a single night looks like when all 7 are in play. At 9:30 at night you're watching TV. Blue light suppresses melatonin. Immune breaks begin to release. At 10 you take your medications, including one with anticholinergic activity. Gland secretion drops further. At 10:30 you lie flat. Sinus drainage slows. Reflux microepisodes begin. At 11 you fall asleep in a room at 22% humidity with the heating on. Tear film evaporation accelerates. At midnight mouth breathing begins. Saliva is stripped. Mucosal tissue is exposed. At 2 in the morning melatonin is suppressed. The anti-inflammatory break is minimal. Cytokines begin their circadian peak. At 3 in the morning Illinois 6, TNF-alpha, and Illinois 1-beta are at peak levels. Immune activity is at its highest. Moisture reserves are at 0. At 5 in the morning the corneal surface has been damaged from hours of exposure. Oral mucosa is severely desiccated. Sinus inflammation is peaking. At 7 in the morning you open your eyes. Everything hurts. Everything is dry. You don't know why. That is the pattern most people miss. It's not just your sleep. It's what's happening during it. An 8-hour cascade of compounding biological events, each one making the next worse. And most of it is within your power to change. But to change it you need to know which ones are affecting you most. Which combinations are creating your specific morning symptom profile. That's not something a YouTube video can tell you. That's what the symptom map is for. I don't want to leave you with just the problems. I want to show you what the opposite looks like. What it looks like when you know this and you change it. At 8 at night devices off or blue light glasses on. Melatonin begins rising on schedule. At 9 1 glass of room temperature water with electrolytes if needed. Hydration topped up. At 9:30 cool mist humidifier running. Bedroom humidity rising to 50%. At 9:45 medications reviewed with anticholinergic alternatives already discussed with your doctor. At 10 high viscosity lubricating eye gel applied. Moisture chamber goggles if needed. At 10:15 biotin gel applied inside the mouth. Nasal rinse used if sinus symptoms are present. At 10:30 head elevated 30 degrees. Wedge pillow in place. At 10:45 a low dose of melatonin taken. Room temperature set to 65 to 68 degrees Fahrenheit. At 11 sleep. Nose breathing. 50% humidity. Melatonin rising. Anti-inflammatory protection active. At 6:30 in the morning waking with noticeably less dryness. Less burning. Less brain fog. A different morning. This is not a cure. Sjogren's is complex. It requires medical management. But this is the difference between working with your biology and unknowingly working against it. I mentioned the Sjogren's nighttime symptom map at the beginning of this video. And I want to tell you exactly what it is. Because it is not a PDF. It is not a checklist. It is a clinical quality reference guide built specifically for Sjogren's patients. Section 1 is your personal symptom pattern mapper. You go through each of the 7 nighttime mistakes and rate which ones match your experience morning by morning. The map shows you which combination of habits is most likely driving your specific symptom profile. Section 2 is the biology pages. A clean illustrated breakdown of every physiological mechanism covered in this video, including the cytokine timeline, the anticholinergic medication list, the corneal damage pathway, and the dehydration inflammation link. Print it. Bring it to your appointment. Section 3 is a 14-day nighttime tracking protocol. A structured daily log that connects what you do at night to what you feel in the morning. After 14 days you will see patterns in your own data that you have never been able to see before. Section 4 is the doctor conversation scripts. The exact words for your rheumatologist, your ophthalmologist, your GP. Specific questions for each of the 7 nighttime issues. Because walking in prepared changes everything about that conversation. This is the tool that turns this video into action. Your action. For your body. It is not free. Because it took significant time to build and because your health deserves a serious tool, not a throwaway download. But it is priced so that it is accessible. And the people who have it are having completely different conversations with their doctors. The link is in the description and pinned in the comments. Get it now. Your mornings can be different. But only if you know what is driving them. What we covered today is the nighttime side of this pattern. But there are specific warning signs that appear in how you sleep, how you breathe, how you wake, that if you know how to read them tell you whether your Sjogren's is being managed or quietly advancing. Signs that show up years before complications become visible on tests. That is what the next video is about. Subscribe now so you don't miss it. And hit the notification bell because this information gets buried if you don't tell the algorithm you want it. Before I go, I need to say something. If you recognized yourself in any of those 7 mistakes, if something in this video made you think that's me, that's been happening to me, I want you to hear this. You were not doing anything wrong. You were doing what made sense. What felt normal. What everyone around you does. You just were never given the information to do it differently. Nobody sat down with you and said, here is what Sjogren's is doing to your body at the cellular level. Here is what happens during sleep that makes morning so hard. Here is exactly what is contributing to that dryness, that fatigue, that fog. And here is what you can do about it. That gap between what patients are told and what they actually need to know is enormous. And it is the reason mornings feel the way they do for so many people living with Sjogren's. But you came here today. You watched this through to the end. And now you know more about what is happening in your own body than most people with this diagnosis ever get told. That knowledge is power. Not power to cure. But power to understand. Power to ask better questions. Power to have a different conversation with your doctor. Power to make changes that give your body a better environment to work with every single night. You are not imagining how hard this is. You are not exaggerating. You are not just getting old. You have a real condition that deserves real information. And you deserve to finally have it. I'll see you in the next one.